scientific formulas for oral nutrition supplements and for enteral tube feedings were first available in India in the early 1990s. And prior to that, kitchen-prepared diets were used. Now, a few words about blenderized diets. The reason why blenderized diets are still being used in hospitals is because of the wrong idea that it is cheaper. And it has been extremely difficult to convince physicians and hospital administrators that this is not the case. Blenderized kitchen-prepared diets do not have a fixed composition, and it has been shown that in the same hospital there is an inter-day variability between morning and evening and from day to day. So if the dietitian feels that he or she is going to be providing a 1,000-calorie diet, in reality that would be wrong by at least 50 to 75%, and this is well established in the literature. Then the composition also may grossly say it is carbohydrates, fats and proteins, but what kind of carbohydrate, what kind of protein, what kind of fat is not really mentioned. But another important aspect of the composition is no one pays attention to the presence of micronutrients. The food scientists may say that so much of rice or wheat or milk or whatever has so much of zinc or selenium and vitamins, but it may not be bioavailable to the patient, and the only way by which you can be sure of bioavailability is to use a scientifically prepared formula meant for enteral nutrition. Another disadvantage is that we always think that it is cheaper. It may be cheaper if you look at the components, but if you look at the cost of procuring, preparation, transportation to the patient's bedside, wastage if the patient is not in the bed and it is sent back or thrown into the garbage, and if you take into account the complications that occur because of blenderized diets, they are actually much more expensive than the scientific formulas. Viscosity is pretty high, and therefore large bore tubes have to be used. You have to use bolus feedings, and bolus feedings are quite problematic, especially in the critical care unit. Bolus feedings would actually cause risks like aspiration, and glucose levels fluctuate very high. Under the best of circumstances, you cannot control glucose levels with bolus feeding, but the most dangerous aspect of kitchen-prepared blenderized diets is the microbiological contamination. Within 4 hours of preparing the blenderized diets, the microbiological content is 10 to the power of 5 or 10 to the power of 8 microorganisms. If this was a restaurant, the government would probably close the restaurant, and yet we are giving this to hospitals. So there are a lot of blenderized diets, a lot of complications of blenderized diets, and if you do a Medline search for the recent literature, I can assure you that you will not find any, because there are no recent publications on this, and it is generally not used anywhere in the world. Scientific formulas and ready-to-feed products are essentially the same. The composition is the same, with mild differences between the two. Therefore, the complications that can occur with one can also occur with the other, and it would be unfair to blame it on whether the product is a liquid formulation or whether it is a powdered formulation. Water has to be added to the powdered form, and therefore the technique of adding the water, making sure that the water is of good quality, making sure that there is no microbiological contamination, and the actual mechanism of giving it to the patient are very, very important. If you look at the textbook on enteral nutrition, it is 300 pages long. It is far more complicated than the physician just telling the nurse, "Sister, give the patient so much of feeding and walk away," because there are finite aspects of feeding which is the only way by which you can diminish complications from enteral feeding, most of which are preventable. with enteral nutrition create excuses not to use it. And one of the common excuses is that the patient has diarrhea. I want to put this into perspective for you. There are 24 definitions of diarrhea. The night nurse says the patient is fine, but the day nurse comes and says the patient has diarrhea. So the very definition is very, very difficult, and enteral nutrition is often blamed. But as has been well published, patients on enteral feeding develop diarrhea because they are patients and not because of enteral feeding. It is always very easy to blame it. But if you do a root cause analysis of why the patient has diarrhea, you will find that very often it is to do with bacterial contamination and problems with the method of administration as well as medications. Now, the first thing that we have to be sure is, does the patient have diarrhea at all? Many times what we find is that the patient has actual constipation or fecal impaction, and the liquid stool comes around it. So the physicians and the nurses think the patient has diarrhea when actually the opposite is true. So a rectal examination needs to be done to make sure it is not a fecal impaction. And then we have to find out a little bit more about the diarrhea. Having 4 or 5 stools a day is not unusual. Many normal people have 3 to 4 bowel movements every day. Bacterial contamination is the biggest problem. Recently, I was in a hospital where I was told that they had this problem, and then I said, I'm going to witness how enteral tube feeding is given to a patient. True, they were using scientific formulas, but the nurse who was doing it did not have a glove, did not wash her hands before administering it. The container in which it was poured was obviously quite dirty, and about 500 cc's was given within 10 minutes. Naturally, when you bolus feed something like this, the patient is going to have diarrhea, and so it is wrong to blame it on the enteral feeding. So if you want to avoid diarrhea, it has to be given in a slow, continuous form, or perhaps 4 hours on, 4 hours off, which is called the interrupted regimen of administering enteral formulas. Bacterial contamination is a very serious problem. The kind of water we use, the contamination from the tubing and the containers, the bags, is the main source of bacterial contamination in enteral tube feeding. Another problem is, many times the patient is actually getting medications that cause diarrhea. So then what is the point of blaming enteral tube feeding? For example, potassium chloride elixir, which is given to correct potassium levels, are sometimes laced with sorbitol for the taste, and sorbitol produces diarrhea. You might have medications like metoclopramide. So one would have to actually look at the medications that cause diarrhea. In the management of diarrhea, remember that after we have ruled out spurious diarrhea, it is wrong to stop the feeding. We cut down the rate of infusion, let's say from maybe 30, 50 cc's to half of that, observe the patient, and then proceed further with bringing up the rate. But you should not stop the rate, stop the feeding abruptly just because the patient has one episode of reported diarrhea, and it may not even be diarrhea, it might be the nurse's own perspective of what is diarrhea. I must also add that Clostridium difficile infections are becoming more common in India. It is mainly because of the overuse or abuse of antibiotics, and in specific situations you have to rule out Clostridium difficile infection, but that is a separate topic altogether. Let's now talk about hyperglycemia, which can occur in hospitalized patients, especially the critically ill patients, either because of pre-existing diabetes mellitus, or it may be stress-related or disease-related. Now, recently we have known that maintaining glucose levels is very important, euglycemia. And of course, the levels have been liberalized to 150 to 180 milligrams per deciliter. But what is more important than the actual level at one time is what is called the glycemic variability, the up and down, and the time factor, whether the curve goes up and down like this or whether it goes down gradually. So these concepts are extremely important, and that is why bolus feedings, whether it is from the kitchen prepared diets, which anyway should never be used in intensive care units and in most hospitalized patients, or whether we are using the powdered formula or the ready to feed formulas, it can never be controlled when it is given as a bolus feeding. Now, I admit that bolus feedings like you and I eat is the most physiological way by which we can provide good nutrition to the patient, because the low glucose levels during starvation helps to bring down the insulin levels and mobilization of fat from the liver. However, it is a nursing nightmare and a physician's nightmare to be able to maintain glucose levels in patients when bolus feedings are given. Therefore, it has to be done by continuous feeding, either through a small bore feeding tube or a short-term use of a large bore feeding tube. You might need insulin drip, a combination of short and long-acting insulins given subcutaneously only in patients without edema. If the patient's glucose levels are difficult to manage, then you can use the disease-specific formulas for hyperglycemia either after the problem has occurred or preemptively. So it is not a hard and fast rule. But hyperglycemia can occur with any product, whether it is a ready-to-feed formula or whether it is a powdered formula. It does not make any difference at all. But the fact is the patient needs the nutrition. And if you need the nutrition, it behooves us to find ways by which you can control the glucose levels. And if proper protocols are maintained, controlling the glucose level is really not very difficult. Now, for us to blame a high sodium level, hypernatremia, on tube feedings or on oral nutrition supplements, either powdered form or ready to feed formulas, is scientifically and clinically not correct. We have to first understand the difference between milligrams and milliequivalents. The product label will always disclose the content of sodium and potassium and calcium in terms of milligrams. But we physicians and clinicians are used to thinking in terms of milliequivalents. That is how we measure it in the blood. A normal serum sodium level is 140 milliequivalents. So this understanding is extremely important. 1 gram of salt, sodium chloride, has 400 milligrams of elemental sodium, approximately 400, which provides 17 milliequivalents, 17 milliequivalents of elemental sodium. Now, our daily requirement is approximately between 80 to 100 milliequivalents. 1 gram of elemental sodium as such has 43.5 milliequivalents. So, when we say that someone needs a 2 gram sodium diet, which is on the low limit of intake, you actually mean 87 milliequivalents of sodium every day. Now, the scientific formulas available in India, they usually have a content varying between 300 to 500 milligrams for about 1000 calories. So let's use just the 300 milligram figure. So it is 300 milligrams for 1000 calories, it is 26 milliequivalents of elemental sodium for 2000 calories. Our daily requirement is now something like 80 to 100 milliequivalents. So it is quite ludicrous to blame. You will find that the very patient who gets the tube feeding and hypernatremia is blamed because of the tube feeding would be getting a liter of normal saline or flushes in the IV. The audience will know that 1000 cc's of normal saline has 154 milliequivalents of sodium. Now here we are talking about 26 milliequivalents for the whole day, and we are giving the patient 154 milliequivalents intravenously, and then we blame the hypernatremia on the tube feeding. So to understand sodium physiology, we should know that sodium is not ever looked at in isolation. It is looked at in terms of the water intake and water loss. Remember that 60% of our body is water. In a ready-to-feed formula, the formula itself has some free water in it, but the free water content is not 100 cc's per 100 cc's. If you have 100 cc's of a ready-to-feed formula, then the free water content in that varies anywhere between 75 to 85 cc's. The nurses will record an intake of say 1000 cc's of enteral formula, and the physician thinks that the intake is 1000 cc's. In reality, it is only about 750 to 800 cc's of an intake. So it behooves the doctor to make a correction in their notes saying the corrected intake is so much. On a single day, it really doesn't matter whether it is 200 cc's plus or minus. But when you look at it 4 or 5 days, suddenly you find that the patient is 1.5 liters positive, and another physician comes and says, well, the patient is fluid overloaded, without really understanding that it was a miscalculation on our part in the first place. Whenever tube feeding is given, we actually have to give extra water to the patient, especially because we give more sodium through the intravenous route. And a good understanding should be made available to even the junior doctors, who are the ones who usually write down the actual prescription for the enteral tube feeding or for the IV fluids. So to summarize, a low sodium can mean either too much water or too little sodium, and a high sodium invariably is because we have not given enough free water to the patient. It is not because the sodium intake itself has been spuriously increased. Refeeding syndrome occurs because the amount of nutrition given to the body is not being metabolized appropriately. And a major component of refeeding syndrome is actually electrolyte disturbances, magnesium, potassium and phosphorus, but it is preventable. It usually occurs in patients who have not been eating for quite a while, patients who have lost a lot of weight, cancer patients for example. But remember, even obese patients who have lost a lot of protein in the hospital and have developed sarcopenia can develop refeeding syndrome. It is therefore extremely important that before we start nutritional support of any kind to a patient, magnesium, potassium and phosphate levels have to be checked. And if it is felt that the patient is at risk for refeeding syndrome, then you should start the tube feedings extremely slowly, maybe 10 to 15 cc's per hour of a formula that is usually 1 cc containing 1 calorie. And then electrolyte corrections take place at the same time following protocols. We all know that magnesium can be given quite rapidly, potassium has to be given very slowly, and phosphate has to be given very slowly too. Now, it is also good news that intravenous phosphate, which was not available in India for several years, is now freely available. And it is difficult for me to understand an intensive care unit that does not check phosphate levels on a patient, because phosphate physiology is absolutely crucial to the body. If you can remember that adenosine triphosphate, ATP, has phosphate in it, and that is actually most important for the metabolism of the body. So I would urge you to check the magnesium, potassium, phosphate levels, also of course the sodium and the glucose levels. Start very slowly and then gradually keep increasing the rate to the level of tolerance. When we look at sodium maintenance in patients, we should also remember the sodium losses. The sodium losses can occur in sweating, in perspiration, it can occur from diarrhea, and it can occur in the stool and in the urine. So we should have a rough idea of how much is lost. We don't have to measure it, but we have to maintain a rough idea. And one of the causes is, of course, the use of diuretics. When patients have fluctuations in fluid balance, you can have, when more water is lost than sodium, you're going to develop hypernatremia. Diuretics also cause magnesium and potassium deficiencies, as we all know. So we should be very sensitive about the drug-nutrient interactions, not only for sodium, but for any aspect of enteral tube feeding. We have to look at drug-nutrient interactions and make sure they are prevented, or prevented to the extent possible, or at least corrected if we can detect that there is a problem. Now, it is really nice that we have ready-to-feed liquid formulas that are now available in our country, because that is the way actually that enteral feeding was originally designed. Now, one could always take the powdered form and one could mix it with water and then put it into a bag and with the appropriate tubing administer it to a patient. But then there are several steps in which contamination can occur, and also if proper precautions are not followed, microbiological contamination can result in a lot of problems. There is also a labor involved in this, and a lot of physicians and hospital administrators do not actually look at the labor cost involved when calculating or deciding what is more cost effective to a patient. We must also understand that in many hospitals, even the powdered form is actually mixed at the patient's bedside. They do not have dedicated units. Some hospitals have, which used to have a kitchen prepared blenderized diet unit, then moved on to the powdered formulas. And then the powdered formulas were prepared in those areas and then transported to the patient's bedside. But then there is a labor involved here, where somebody is mixing it, somebody is taking it to the patient's bedside, and there is also a question of wastage if that product is not used, because it has to be used between 4 and 6 hours maximum. The benefit of the ready-to-tube feeding is that everything is ready, and at the point of delivery, the delivery system is connected to the bag or the bottle and then administered to a patient. The cost factor is something that one will have to really think very carefully and realize that the labor cost should also be involved. Not to mention the complications that can occur because of wrong mixing or contamination that can occur. It is impossible for us to designate a separate area in an intensive care unit only for the purpose of enteral tube feeding, because that space may rather be used for some other beneficial purpose, or maybe another hospital bed. The ready-to-feed liquid preparations obviates the need for that, and it is given to the patient at the bedside, and which is the way this is done in most parts of the world. A question that is often asked is, how early is early enteral feeding? We all know that early enteral feeding is extremely important for various reasons, and it is the only thing known to mankind today to prevent the protein catabolism that occurs in critically ill patients, causing loss of lean body mass. No medication works on it. The only way to prevent it is by early enteral feeding. But how early is early? The recommendations will say anywhere between 24 to 48 hours. But starting it even early, as early as 6 hours, is not harmful. It usually takes a little bit of time in the post-operative period or after admission to the ICU, where we are concerned with hemodynamic stability and other factors, and so there is some delay in initiating enteral feeding. But then we don't know much about whether the patient is going to tolerate it or not. So in general, one would start at a rate which we expect the patient to tolerate. I can't actually tell you what rate to start this on. In general, we start at rates of maybe 15 to 20 cc's an hour, and then we gradually increase it. If you think that the patient can actually tolerate it and there is no reason why we would expect them not to, then starting even at a higher rate of 25 to 30 cc's per hour is quite all right. There is no difference between the ready-to-tube feeding, ready-to-feed liquid formulas and the powder formulas. It is only a question of adding the water to the powder formulas. It is a question of the convenience. It is a question of labor saving and cost saving when you have the ready-to-feed liquid formulas that just have to be spiked and given, very much like an intravenous preparation. So I would like folks to think about the enteral tube feeding on the same light as a parenteral feeding. Not parenteral nutrition, but parenteral intravenous crystalloid infusions. It is the same thing. It is more convenient, easy, and definitely it is more sterile.